Discover the 2 key clues that point you towards specialized renal imaging instead of more medications. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 43-year-old man returns to nephrology clinic for follow-up of apparent treatment-resistant hypertension diagnosed 4 months ago. Home readings remain 165 to 180, over 95 to 110 millimeters of mercury, despite reported adherence. His father developed hypertension in his 40s and had myocardial infarction at age 68. The patient has schizophrenia, compensated metabolic dysfunction-associated steatotic liver disease cirrhosis, child PUA, idiopathic pulmonary fibrosis, chronic plaque psoriasis, bilateral high-frequency sensorineural hearing loss, and migraine without aura. He does not smoke, use illicit substances, take non-steroidal anti-inflammatory drugs, or use herbal products. He reports no episodic palpitations, flushing, orthostatic symptoms, exertional chest pain, transient neurologic symptoms, or prior flash pulmonary edema. Current medications are amlodipine 10 mg orally daily, metoprolol tartrate 100 mg orally twice daily, hydrochlorothiazide 25 mg orally daily, lisinopril 10 mg orally daily started 2 weeks ago, risperidone 2 mg orally nightly, and nintedanib 100 mg orally twice daily. He reports adequate oral intake and no recent diarrhea, vomiting, or diuretic overuse. Vital signs are temperature 36.8 degrees Celsius, pulse 92 per minute, respiratory rate 14 per minute, blood pressure 182 over 106 millimeters of mercury in the right arm while seated, and oxygen saturation 94% on room air. Repeat automated readings are concordant in both arms. Fundoscopic examination shows no hemorrhages, exudates, or papilledema. A loud, continuous right paraumbilical bruit radiates posteriorly. There is no peripheral edema, carotid bruit, pulse asymmetry, livedo-reticularis, or abdominal tenderness. Fine bibasilar inspiratory crackles and stable psoriatic plaques are present. Laboratory results show serum creatinine before lisinopril of 1.02 mg per deciliter, normal, 0.7 to 1.3 mg per deciliter, and serum creatinine today of 1.49 mg per deciliter, normal, 0.7 to 1.3 mg per deciliter. Serum potassium is 4.2 millimoles per liter, normal, 3.5 to 5.0 millimoles per liter. Bicarbonate is 24 millimoles per liter, normal 22 to 28 millimoles per liter. Fasting glucose is 96 milligrams per deciliter, normal 70 to 99 milligrams per deciliter. And low-density lipoprotein cholesterol is 118 milligrams per deciliter, optimal 100 milligrams per deciliter. Urinalysis shows no blood or cellular casts, normal, absent, and urine protein to creatinine ratio is 0.08 grams per gram, normal, less than 0.20 grams per gram. A 24-hour ambulatory blood pressure study last month confirmed sustained daytime hypertension. Electrocardiography shows voltage criteria for left ventricular hypertrophy. 6 weeks ago, renal ultrasound showed a right kidney measuring 8.2 centimeters with cortical thinning and a left kidney measuring 12.1 centimeters with preserved cortical thickness. Which individual finding most strongly supports a hemodynamically important unilateral renal artery lesion and warrants dedicated renal vascular imaging rather than simple escalation of antihypertensive therapy? Option A, migraine with bilateral sensorineural hearing loss and no documented connective tissue disorder. Option B, a loud continuous right paraumbilical bruit radiating posteriorly without another localizing finding. Option C, right kidney length of 8.2 centimeters with cortical thinning versus a 12.1 centimeter contralateral kidney. Option D, a 46% creatinine increase after lisinopril with normal potassium and a bland urine sediment. The correct answer is option C, right kidney length of 8.2 centimeters with cortical thinning versus a 12.1 centimeter contralateral kidney. The strongest clue is the marked unilateral renal size discrepancy. The right kidney is 8.2 centimeters with cortical thinning, whereas the left kidney is 12.1 centimeters with preserved cortex. A small, chronically scarred kidney suggests sustained hypoperfusion of that renal unit and provides an anatomic consequence of a clinically important unilateral renal artery lesion. This finding occurs in the setting of confirmed sustained hypertension, despite multiple medications, a right-sided abdominal brute, left ventricular hypertrophy, and a bland urinalysis with minimal proteinuria, which favors renovascular disease over a primary glomerular disorder. Dedicated renal vascular imaging is therefore justified rather than simply adding another antihypertensive agent. A continuous paraumbilical brute increases suspicion for renovascular disease, but is neither sensitive nor specific enough to establish lesion severity or laterality by itself. A 46% rise in creatinine after lisinopril is clinically important and requires reassessment of volume status, medications, and renovascular disease. However, it is a functional clue rather than the most direct evidence of a chronic unilateral ischemic kidney. Normal potassium and bland sediment do not localize the lesion. Migraine and bilateral sensorineural hearing loss are not a validated imaging trigger for renal artery disease in the absence of a defined systemic arteriopathy, connective tissue disorder, or other vascular manifestations. In summary, the correct answer is the marked right-to-left renal asymmetry with cortical thinning because it most directly indicates chronic unilateral renal hypoperfusion. Primary teaching point: in suspected renovascular hypertension, asymmetric renal size with an atrophic kidney is a high-yield structural clue that supports renal vascular imaging. Secondary teaching point: a creatinine rise after renin-angiotensin system blockade is important but is not by itself proof of a unilateral renal artery lesion. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.